Firstly, at the outset, I'd like to thank Dr. GVK, who's the organizer for this conference, and other organizers to invite me to talk to you. This very esteemed panel of, or esteemed, diabetologists around. And to my very pleasant surprise, I found Professor Vijayakumar Das, who was my teacher in general medicine while I was an undergraduate and postgraduate in JIPMER. So that's indeed another additional privilege for being here. So anemia and diabetes, I think this is the second time I'm doing this talk. First time I found it a bit challenging to put together something, a kind of semblance of a talk in this, seemingly very disparate issues. But as I prepared for the talk, I found that there is indeed certain aspects of anemia that directly impacts on diabetes care, and also that there are certain issues within diabetes which also affects the hematological system. Okay. So anemia in patients with diabetes is commonly associated with impaired renal function secondary to diabetic nephropathy. The prevalence is around 20 to 25% in diabetic populations. Females tend to be more anemic than men. And importantly, anemia is also seen in patients with normal renal function. So there must be something about diabetes which causes anemia in, anemia. There are many causes for anemia, like iron deficiency and certain other autoimmune issues. And sometimes the cause for anemia and diabetes remains unknown. So the first statement is like what you all commonly find in de Gruchy's textbook. Anemia can be, in diabetes, can be normocytic, microcytic, or macrocytic. So it encompasses all kind of features related to red cells. Rarely, anemia can be also secondary to direct glucose toxicity to erythrocyte precursors in the bone marrow, or from oxidative stress to mature erythrocytes. So if you look at prevalence of anemia, as I told in the first part of my first few minutes of my talk, females have higher prevalence of anemia, and there is an impact of control of diabetes in the prevalence of anemia. So if you have poorly controlled diabetes, there's a higher incidence of anemia. So why is anemia important? Why should anemia be recognized in diabetes and treated? There are studies which show that there is an increased risk of vascular complications of diabetes. There's increased risk of neuropathy and impaired wound healing and macrovascular disease in patients with anemia and diabetes compared to non-anemic diabetics. Anemia exacerbates severity and impairs outcome of peripheral small vessel disease in diabetic patients. The NHNES3 reported that patients with diabetes were twice as likely to have anemia compared to those with similar degree of renal impairment from other causes. So there's something about the hyperglycemia and diabetes which does directly affect the erythrocytes and erythroid precursors, resulting in anemia. Patients with diabetes, especially type 2 diabetes and anemia, were those with high body mass, hypertension, increased waist circumference, and seem to have a longer duration of disease. And anemia does impact on quality of life of diabetic patients. So looking at the cause for anemia and diabetes, if you exclude diabetic nephropathy, there are many reasons why anemia impacts there are many mechanisms of anemia and diabetes. It might be due to tubulointerstitial disease, chronic renal hypoxia, hyperglycemia and its direct effect on red cell precursors and red cells. Diabetes is an inflammatory condition, therefore inflammation may result in anemia. There is also some role for symptomatic autonomic neuropathy causing efferent denervation of the kidney, resulting in low erythropoietin levels or loss of appropriate erythropoietin production. There's also abnormal iron metabolism because of diabetes being a hyperinflammatory state. There's also altered iron metabolism which results in anemia. And there's also inhibition of erythropoietin release, and there are certain medications that we use in diabetes which can result in anemia. So this is a cartoon which tells us about the impact diabetes has, the mechanisms that diabetes has in terms of causing anemia. So type 2 diabetes causes endothelial dysfunction, and also type 2 diabetes is a chronic inflammatory state, which means you're going to have increased pro-inflammatory cytokines. That's going to result in increased oxidative stress, Because of all these increased pro-inflammatory cytokines, there is a direct effect on the kidney, which impairs release of erythropoietin. We know that increased inflammation results in increased hepcidin, and we know that hepcidin as a hormone will result in impaired absorption and impaired utilization of iron. And there's also reduced RBC lifespan due to hyperglycemia per se. So the end result of anemia is a complex process, which interplay in resulting in low hemoglobin in diabetic patients. So one interesting aspect of anemia is that presence of anemia influence HbA1c levels. So if you have a patient with anemia, especially iron deficiency anemia, they tend to have a higher HbA1c levels, though their glycemia higher, though they may not be significantly hyperglycemic. So iron deficiency anemia elevates HbA1c level in diabetic individuals with controlled plasma glucose levels. So the elevation is more in patients having plasma glucose levels between 100 to 126 milligram per deciliter. Hence, before altering the treatment regimen for diabetes, iron deficiency anemia should be considered. So there is an impact of anemia, especially iron deficiency anemia, when you measure HbA1c level. So iron deficiency anemia is associated with higher concentrations of HbA1c. It's also not unique to iron deficiency anemia. Any severe anemia can result in higher concentration of HbA1c, but paradoxically, if you have extremely severe anemia, you can have a lower HbA1c as well. But important to remember that iron deficiency anemia results in higher concentration of HbA1c. Iron replacement therapy decreases HbA1c level in both diabetic and non-diabetic individuals. This implies that the iron states must be considered when you're interpreting HbA1c concentrations in diabetic patients, and also when you're using HbA1c levels to screen non-diabetic individuals. So early diagnosis and treatment of iron deficiency in diabetic patients can improve their glycemic control and may prevent or delay complications. So that's the importance of recognizing anemia in patients with diabetes. So this is, so based on these things, there was this very interesting kind of warning that iron deficiency may lead to false diagnosis of diabetes. So just to read out from this article, HbA1c is likely to be affected by iron deficiency and iron deficiency anemia with a spurious increase in HbA1c levels. This may lead to confusion when diagnosing diabetes using HbA1c. So this review, based on many other studies, clearly tells you to take into account presence of anemia, especially iron deficiency anemia, when you interpret HbA1c levels. So there seems to be, as we just discussed earlier, there seems to be a higher incidence of iron deficiency, higher frequency of iron deficiency anemia and type 2 diabetes. And this study clearly demonstrated that the prevalence of iron deficiency anemia was nearly 40% and was higher amongst women, and especially in the age group of 50 to 60 years. And the independent risk factors for iron deficiency anemia were female gender, duration of diabetes, and fasting, high fasting plasma glucose. And identifying and monitoring iron status and anemia was considered the need of the hour. This is based on a paper that was published, I'm sure, from India, and it's got some authors who probably are in the audience. So this is kind of a basic overview of anemia. So I just thought, well, we'll just look at some case examples. So case 1, 48-year-old female. See, I've put some HbA1c levels and blood sugar levels and some diabetic medications. My knowledge of diabetology after leaving JIPMA has nosedived to the very depth. So just excuse me if I have written anything wrong in terms of anti-diabetic medications. But these cases are just to illustrate certain aspects of hematology that may impact on diabetes care. So diabetic since 12 years on oral hypoglycemic agents, metformin and gliclazide since last 5 years, pallor. So he had a hemoglobin of 7.2, total count of 8.7, and platelets of 385, and MCV was high, suggestive of macrocytosis. So normal renal and liver parameters. So whatever the fasting blood sugar and HbA1c level was. So this sometimes we do come across, not infrequently, that patients with diabetes do come to us with certain anemias, and so this does happen once or twice in a year or even more. So I'm sure you're all thinking of what could be the cause. So type 2 diabetes, metformin related. So this is probably metformin related anemia. So macrocytic anemia. So usually metformin-related anemia is B12. It's related to low B12, and it is B12 and folic acid responsive. So although I'm saying just change metformin to alternate OHs, it's not always necessary. I'll come to that at a later point in this talk. So what is the mechanism for metformin-induced vitamin B12 deficiency? There's increased liver accumulation of B12. There's alteration in small intestinal motility resulting in bacterial overgrowth and therefore decreased absorption of B12. There is interference with the calcium-dependent binding of intrinsic factor vitamin B12 complex to the tubulin receptor. And there is impaired enterohepatic circulation of vitamin B12. And there's also gastric parietal cell dysfunction. So there are many mechanisms by which metformin causes B12 deficiency. So metformin can commonly reduce B12 levels, which may lead to B12 deficiency. Risk of low vitamin B12 increases with higher metformin dose, longer treatment duration, and in patients with risk factors for vitamin B12 deficiency. So you have to test serum vitamin B12 levels if you're suspecting either new onset neuropathy or there's a sudden onset of macrocytic anemia. And if patients are on metformin, you should consider periodic vitamin B12 monitoring and need to administer corrective treatment for vitamin B12 deficiency in line with clinical guidelines, which is pretty straightforward. So this was published in Diabetes Care 2020. This looked at risk of anemia with metformin used in type 2 diabetes. This was called the Mastermind study. I think it took into account 3 studies, the ADOPT and UKPDS, and also there was another study, I think it was the GO-DARTS, which is kind of more in the community. So I just picked out the final conclusion from this analysis of 3 studies which looked at anemia in patients who are on metformin. It said that the absolute hemoglobin reductions are not large. So 0.5 grams per deciliter at 5 years with ADOPT and 0.5 at 3 years with UKPDS. Overall effect on the real world population is about 2% increased risk of anemia per year per 1 gram per day of metformin. And it's greatest in the first year. So if you want to use this study to strategize how you want to screen this, maybe just do blood tests to look for anemia, and if there is macrocytosis, especially in the first year, maybe one has to be very vigilant. Because the mechanisms for metformin-related moderate anemia are unknown, the effects are modest and the benefits of metformin are proven, we would not in any way advocate avoidance or discontinuation of metformin even in patients with anemia. This was the conclusion from this particular study. A reduction in hemoglobin in the first few years after initiation of metformin should be anticipated and, if needed, corrected. So I had to put some kind of correlate diabetes and anemia. So another case, which is probably not that uncommon, 27-year-old male, diabetic since 9 years on insulin, problems with digestion, lactose intolerance, frequent episodes of bloating, diarrhea, constipation, and had pallor. So this was his blood counts. So at this time, MCV is 68. So he's got microcytic anemia with a mild thrombocytosis. So one of the most common causes of microcytic anemia, of course, is iron deficiency, normal renal and liver parameters. Okay. So ferritin 7.2. There is no other cause for low ferritin other than iron deficiency. For high ferritin, there are many causes. So patient was on long-term iron therapy with poor tolerance. So what could have happened? So there is of course, celiac disease is extremely uncommon in our population, but still now and then when you're looking at patients with refractory iron deficiency, you do come across celiac disease. So there is a clear association between type 1 diabetes and celiac disease. So the mean prevalence of celiac disease in type 1 diabetes is about 8%. And it's very important to recognize that you may not have classic intestinal symptoms. Very often, I know it's very uncommon in India, the ones we diagnose are the ones where they have severe iron deficiency anemia, which is just not unresponsive to your management. Then you proactively look for celiac disease. So case 3, 25-year-old female, diabetic since 11 years, on insulin, again anemic with slightly macrocytic indices, dyspepsia, bloating on eating spicy food, pallor, normal renal and liver parameters. So this lady had both low ferritin and B12. This is sometimes you do get this kind of scenario where they have combined iron and B12. what one has to remember, either diabetic or non-diabetic, if you have combined iron and B12, it's rarely dietary. It's due to a common defect in an absorptive mechanism. So we do see a lot of patients with autoimmune gastritis in patients with type 1 diabetes, autoimmune gastritis and pernicious anemia. So if you see this kind of picture, you have to kind of start thinking about an autoimmune gastritis. And the prevalence in type 1 diabetes is about 3 to 5 folds higher than general population. So this is because of atrophy of the corpus and fundus, autoantibodies to the parietal cell and to intrinsic factor, causes hypergastrinemia, iron deficiency anemia, and also low B12 due to low intrinsic factor. Okay. So there is a high prevalence of autoimmune gastritis in type 1 diabetic patients, and there's definitely an adverse impact of this situation in the health of the patient. Okay, we've got a few more minutes. 55-year-old male, diabetes since 17 years on insulin. Excuse me for all these diabetes details. These are real life cases. You do find them. I just put up some kind of imaginary values. So hemoglobin 7.4, total count 6.9, and normocytic normochromic anemia. So this is probably one thing we do commonly see in patients with advanced diabetes. Pallor, pedal edema, proteinuria. So this patient had normal liver parameters and poor control of diabetes, but had a creatinine of 4.2. And ultrasound abdomen showed altered ecotexture of both kidneys with loss of corticomedullary differentiation. So patient had a ferritin of 98, so it's a normal ferritin, and low transferrin saturation and low iron levels. So again, what could be going wrong with this patient? So this is diabetic kidney disease, which is again very straightforward and often is complicated with anemia. So if you look at kidney disease per se, if you compare diabetics and non-diabetics, the degree of anemia is much worse in diabetics compared to non-diabetic patients with chronic kidney disease. So that is something to remember. And anemia has a negative impact on quality of life, which I think in the interest of time, we'll just skip through certain things. So there are several factors which have been implicated in the development of anemia and CKD, especially erythropoietin deficiency, iron deficiency, and hyperglycemia-related changes on the erythropoiesis, chronic blood loss, secondary hyperparathyroidism. So there are several things that happen in diabetes which probably results in in severe anemia than in patients with non-diabetic CKD. So CKD-associated anemia is often a normocytic normochromic anemia, and although anemia may be diagnosed in patients at any stage of CKD, there's a strong correlation between the prevalence of anemia and the severity of CKD, and it's due to decreased erythropoietin synthesis, although there are many other mechanisms. We've only got 2 minutes. So this is something to remember when you see your CKD patients with anemia. Their range that is defined to diagnose anemia is not the same as normal population. So absolute iron deficiency in a CKD patient who is non-dialysis dependent, diabetic or otherwise, is less than 100. And a dialysis dependent patient is less than 200. And your transferrin saturation is less than 20%. That you have to recognize so that you replace iron proactively. Another concept in CKD is functional iron deficiency. Functional iron deficiency is where you have ferritin is high, and that is due to several inflammatory markers. But the transferrin saturation, which tells you the efficiency of iron utilization, that is low. So just to conclude, anemia is a very common accompaniment of diabetes, type 2, and several other metabolic syndromes. So there are many mechanisms: chronic hyperglycemia, autonomic neuropathy, chronic inflammation, poor diet, metformin use, autoimmune gastritis, celiac disease, B12, folic acid deficiency. And also, all this will result in a decreased erythropoietin production and decreased erythropoietin response, resulting in anemia. So you should proactively, when you do a regular checkup in diabetics, apart from the several things that you do, you should look at their blood counts and proactively investigate and address the issue of anemia. Thank you very much.